So good afternoon, everybody. We're so excited to have you here. It has been a great day of sessions. Today, we have Dr. Damian here to talk about advocating in the pediatric ICU. For our icebreaker, we are going to ask you to, in the chat, go ahead and put what your favorite city is. Now, we go ahead and get started in just a few minutes or in just a few moments, but remember, we're going to do Q&A at the end. We'll do a trivia question. And so be sure to go ahead and put those questions throughout the presentation into the Q&A, and we'll answer those at the end. But right now, I am happy to introduce Dr. Damian, who is a critical care attending at Stanford Children's Hospital. And again, she is here to talk about advocating for your child while in the pediatric ICU. Dr. Damian, welcome, and thank you for being here today.
Thank you very much. I'm very delighted to be here and honored to join you guys. So let's see. Thank you so much. I appreciate it. So today I am going to talk a little bit about what does it mean to advocate and be in the ICU, and how can we help everybody to have the best journey in the PICU. I'm, as Sarah said, I am one of the Pediatric Intensive Care Unit attendings at Stanford Children's Hospital. I've been working in ICU since 2009, and my work has been focusing on both liver as well as kidney transplantation in children. One of my questions to you is how do you feel when you get the phone call and say you get the call that's saying, hey, your little one has an offer for transplantation? And my first word that comes in my mind is hope, because it's been a very long journey for some of you. For some of you, it's been short but very unexpected. But also at the same time, there is a lot of stress. There is a feeling of being lost and anxious and afraid of what is going to come next. This is one of my patients. His name is Damian. He was born 6 weeks pre-date, and everything looked great. Baby was healthy, looked healthy and eating. Mom and dad were excited about their little boy. However, this was not easy. When he was 6 days old, he had circumcision done and he started bleeding, and it was really, really hard to stop the bleeding. So the doctors checked some labs, and they found out that little Dane had it was in liver failure, and he got very, very, very sick. He was already in the NICU because he was born prematurely, and he ended up getting a breathing tube. He ended up needing to be dialyzed because both his liver stopped working as well as his kidney stopped working. It took about 6 weeks for him to receive a liver transplantation. He was still, when he got his liver, he was still 5 pounds in his weight. And it was one of the smaller babies getting liver transplantation. And this is his little liver. And you can see there is no question why the liver didn't work. However, he survived, and he, day by day, he spent probably a total of 2 months in the ICU, and each tube came out, one after other. However, his kidney function did not recover, and he required to be dialyzed for a very long time after his liver transplantation. On the right, he is here when he came back for one of his multiple hospitalization after his liver transplantation. He eventually received a kidney transplant 4 years after his liver transplant, and here's with his brother. And today he is 7 years old. He is extremely active. He's skiing. He has a little bit of difficulties with, some delay in speech, delay in motor functions, but he is doing amazing. And this is a very, very happy story, and one of the reason why I really enjoy working with transplant, both physicians and teams, but also taking care of patients needing or receiving a transplant. So PICU, what is it, PICU? It's a very specific unit in the hospital that takes care of the sickest kids that are in the hospital. It gives the best quality of care and high quality of care. It's very specializing in care of taking care of those kids that need a lot of extra support. They need to be intubated. They need sometimes breathing machines. Sometimes they need heart machines, and of course dialysis to be dialyzed. As many of you remember, the rooms can be very busy. This is one of the rooms at Stanford. We are extremely lucky because we do have an amazing hospital that provides one of the best environments for the kids and their family. All the rooms are private, and in an ideal situation, especially after liver transplantation, any kind of transplantation, actually, it should be a private room because of the infection risk. And there are many monitors and lines and tubes that it can be very, very scary. The pumps are to deliver medications. We monitor the kids in the ICU every single second, and through the monitor we see what the heart rate is, what the breathing pattern is, what is the oxygenation, and what's the blood pressure, and how all those numbers guide us on what to do next and what's the best way to do this. So PICU can be very, very scary because you guys, when you come to the ICU, as I said, there is a lot of hope that the future is going to be bright. But in the same time, seeing your little one with most likely sedated with lots of tubes, there's a breathing tube, as I said, there can be a lot of tubes coming from the belly or from the chest, depending if there is a heart or lung transplant. Lots of medication, lots of words that you did not hear before if this is your first time in the ICU. And it's our job to make sure that you feel comfortable and welcomed, and in the same time, all the questions are answered. There is a very specific way how we do take care of kids in the ICU. At our institution, 7 o'clock is the time when we have new nurses. 7 o'clock in the morning and 7 o'clock at p.m. At night. They have about 20 to 30 minutes when they talk to each other, and it's called, we give report about what happened overnight, what the plans are for the next day, what concerns the medical team had about the child that they took care of. And after the report, the new nurse will check everything that she was told. She will check the medication. She will check the pumps, the ventilatory machine, if there one. She will examine your little one and make sure that everything it's the way how she was told, and see exactly what she has to do for the day. In general, especially right after the transplantation, there is only one patient per nurse, which means that the nurse will have all her attention dedicated to the patient. And the day continues with medical rounds, which it can happen at different times, usually between 8 and 12. It can be a very challenging time of the day, because all of a sudden you'll see outside of the door 20 people sometimes, that some of them some of them you don't know. So at least at my institution, we have the ICU team that we have the bedside nurse will present us all the numbers that we want to hear about what happened overnight, all the labs, all the vital signs, any events that happened. And then the resident will take over and will add any other details that the nurse did not present, and we'll come up with a plan for the day. We have the transplant team joining us for rounds, and what I really want to focus on is that we, even if you don't see all the physician at the bedside all day long, there is continuous discussion between us, and sometimes we talk to each other maybe 10 times a day, and anytime when something happens, we update each other, and we come up with a new plan. And we have a respiratory therapist as well. We can have the case manager, we can have the social worker, and the list goes on and on and on, and how many people are there. This is an amazing time for everybody to try to be there and really understand what is going on, and for you to ask questions and ask for clarification if there is something that you don't understand, or something that doesn't make any sense. And it's the best time for those questions to be asked. There, as I said, there can be many words that you don't understand, and this is very important to make sure that you know what the ABG is, what the MRI is, and what stat means. And sometimes stat is like we want it right away, but if you hear the word stat, especially for getting labs, it means that we want to get the labs as soon as possible. And sometimes we have, delays in getting labs, and we may order the lab stat because we want to get as soon as possible. Not necessarily because, your little one is in any danger, but we need the results to make some decisions. PICU, as I said, many teams, and there is a lot of interactions between us. And PICU team, it's the team that is your liaison with every single other teams that are involved in the care of your little one, and can be, if it's a lung transplant, the lung doctor will be there, the liver patient, the liver doctor will be there, and going on and on. Some of us have something that is called the whiteboard, where it's in the room somewhere where it's visible, and we try to use this as a communication tool for us. And this way you'll know exactly who your nurse is, which team do you have. Sometimes there are ICUs where they have many teams, and it's a specific team for example, for us, all the transplant patients are admitted to team B, and it's just a letter, but for everybody, in the hospital, we know which members of the team to ask questions. But also, like there's some space where we want to put any questions that we have for us to communicate with you, meaning that this is what we're going to do for today, but also for you to ask us and to have a space where, like if you have, let's say before rounds, you have a question, and if you don't want to forget, you can just write on the board, and when we are in the room, you can ask us. What is very important, and I believe that all hospitals have this, it's called family-centered care, which means that we want to do to provide the best care possible in a very family-centered way, and we want to have dignity and respect. That means that everybody listen to each other, and we are going to listen to your patient and your family perspective and what choices you have, and make sure that we will accommodate anything that will allow you to respect your choices. But also, we value your knowledge, your values, your beliefs, and all the cultural backgrounds that you are coming from, and having in mind all those issues, will come up with a plan and will deliver the care that we need to. Information sharing, it's very important to be open, and everything that we know to be shared. We have different ways how we communicate with each other, and we need to make sure that when we share information, you receive the information in a timely manner, it's complete and accurate, and make sure that you will participate in the care and decision making that needs to be done. We want your participation, because without you, we cannot make the best decision for your little ones. And it's very important to have participation from everybody involved in the care. And more than anything else, we want collaborations. This is not the time to be one-sided decision, and we want to have collaboration in any aspect of the patient care. We want to know exactly how can we go from having your little one receiving the transplant, but also have the best outcome. And we do it by talking to each other and making sure that it is done in the best way. We also have to keep in mind that the hospitals where transplantation happens are academic centers, and we have a lot of trainees that are involved in the care of our patients. But also, one of our goals is to provide the care while also performing research, meaning that we want to make sure that from what we learn from each patient will be can be applied to the next patient, and the care will be better and better every day that we do this. And here is one of my other patients that actually I took care of this patient during my fellowship, and she had biliary atresia and a bunch of cardiac malformalities as well. So the first time I took care of her was in the cardiac ICU when her had open heart surgery, followed by her taking care of her when she had her liver transplantation, but also many times after liver transplantation when she needed to be admitted in the ICU. Now she's 12 years old, and every time when they come to the clinic and we cross paths, it's so so nice to see her, how she grew, and such amazing. Yeah, it's something happened and my slides went away. Well, my next slide was thank you. And I was expressing my acknowledgement for the Stanford PICU team, as well as transplant, and you guys for doing all the amazing work that you are doing. And I'm more than happy to answer any questions.
Well, thank you so much. I know when my daughters had 2 liver transplants, and I know we spent a lot, and both of them had complications. So her first ICU stay was like 11 days, but her second one was 25, which was a long time. And I know that my favorite with the ICU nurses and doctors and everybody was that they love transplant patients because they get better, right? Like a lot of kids, unfortunately, come into the ICU don't. And so that was always, they said they loved seeing them later. And so I thank you for those stories. So one of the questions that we have first is, if you have a concern or a question, who is the best person to go to first? Or, who do you think you should go talk to as a parent?
I think that it depends. It's a very good question, but it depends on what kind of concern it is. I would say that probably the PICU team will be the first to ask, and the PICU team can direct the question if it's something that they cannot answer. For example, let's say if there is a concern regarding what's going on, like if there misunderstanding is a misunderstanding on the situation, or like what needs to be done first. I would say, ask the PICU attending or ask the PICU resident who takes care, or the fellow. We have many providers involved, and the questions will be asked.
Okay. So then how do you find out who the chain of command is? Like, I know it's kind of a delicate balance of wanting to be involved and make sure and trust your expertise, but also, to know that we're a parent, and when something feels wrong with our child or we have a serious concern, if that first person isn't listening to us or we don't feel heard, what do you think is the next level that, what would be your best advice for that?
Well, again, like this happens all the time, right? So there are concerns, and I would say ask your bedside nurse first. Say, hey, this is my concern. Please, can you please help me to have this addressed? And the nurse can also direct the question towards who needs to be done. If the answer is not sufficient, please do not hesitate and say, hey, may I please speak with the attending? I have this concern and I would like to speak with my attending. Again, like if that's still not the case, you can reach to, speak with my surgeon, and, go from, each one at a time. Also, each hospital has something that is called patient experience, or something similar, that is a group of people that advocate for patient and their families. Your social worker, it's another very good resources to help out. It's anybody can be there to help.
Okay.
The most important, I think, that if you do not get the answer or the answer doesn't satisfy, please ask the further. Go ahead and find another somebody else to call. Some hospitals also have a way how to raise concerns. So for us, some hospitals say, hey, I have a concern. And what happens, for example, what we're going to do at Stanford is we'll call a huddle where everybody that is involved in the care of that patient will meet and we'll discuss the concern.
Okay, I appreciate that. I think a lot of parents don't know that it's okay to ask questions, right?
Yes,
And
it's absolutely okay.
Right. Okay. And then I know you kind of said that rounds is probably would you say that is the best time to ask questions is during those morning rounds when everybody's there, or?
Anytime, the morning rounds, it's one of the best time because everybody is going to be around and everybody can answer the question. However, it can be very intimidating seeing 20 people and parent may not feel comfortable asking a question. So if that's the case, we can meet afterwards. And I think it's also very important from the beginning to have to talk to your team and say, hey, this is how I like to communicate with you. I would like to have I want to participate in rounds, or I want to meet with you after rounds, or 12 o'clock after we have everybody discussing, and then you can give me all the information that I need. But I think it depends on every level of comfort of everybody, and also it's very important for non-English speaking families to advocate for themselves and say, hey, I don't speak English, I do need to have a Spanish or Mandarin interpreter or whatever that is every single day. And most of the ICUs have interpreters even during rounds and can translate every single word that we discuss.
Okay, that's good to know. I think that is a big thing, right? The language barrier, especially when, for transplants, a lot of families fly in internationally to locations. Yes. So that's great.
Yeah.
I didn't see any more questions, but I do have a question.
Of course.
Which is, one of the perspectives I got is that, in the ICU, you're looking like hour by hour, right? Like what's going on this hour, where maybe transplant doctors are more like long-term, big picture, So sometimes I know there can be kind of, conflicts maybe in what the direction to go is, if there's a complication, things like that. How does, I know it could depend on the center, but at the end of the day, is it usually transplant or the ICU who makes the decisions, or are they joint? If there is a disagreement on a plan?
Mm-hmm. In general, it's a joint decision. At the end of the day, it may end up on depending on what the question is. If it's a disagreement on on ventilatory moves that we need to do to provide the best respiratory support for the kid, that I would say that probably the ICU should have more words to say and more weight on the decision. But if it's a surgical decision, then the surgeon will be the one who will have the last say. But again, like it's a collaboration. It's a joint decision, and if we do have disagreements, and it happens to have disagreements, it's a way we discuss and try to understand each one's point, and then at the end of the discussion, we'll do the best for the child.
No, that makes a lot of sense. Well, Dr. Damian, I really appreciate it. We do have one trivia question that I just want to get out for everybody for an Amazon gift card. So the question is, true or false, everyone can register for an organ donor, even if you're older or sick. And so go ahead and throw in your true or false. We're going to pick a random winner for this one. I think that this group is probably going to know the answer to this one. This is not really a trick question for this group, right? I think we all know that one. And next, everybody, so Dr. Damian, again, thank you so much for coming. This is so great. I think advocating for your child in any environment, but especially in the scariness sometimes, or the overwhelming of being in the ICU, is such a great thing to give our parents that courage to do that. But everybody, if you like, when you leave this session, there's a network session open. You can go talk to other parents, and we'll encourage you to go there. And thank you again.
Thank you.